Hi, Rita, are you present?
I'd like to welcome all our audience today to our quarterly Southeast chapter of SCCM meeting. We always start our meetings with our mission and vision. So all right, I apologize for that. So we always start with our mission and vision, and our mission is to secure the highest quality of care for all critically ill and injured patients in the Southeast region by providing educational and research opportunities, as well as promoting multi-professional collaboration. Our vision, therefore, is that all critically ill and injured patients in the Southeast region will receive care from a present integrated team of dedicated trained intensivists and critical care specialists, as well as inspire new leaders and providers of critical care in the region. That said, I would like to remind everyone that our chapter covers 7 states in the Southeast. It is a multi-professional organization. We're always looking to encourage SCCM membership as well as chapter membership to help with networking and learning opportunities as well as advancement opportunities within the region. Today, we have the honor of hosting Dr. Lauren Sorce, SCCM President-elect, who will be talking to us about the team dynamics of the critical care team. More information will be shared regarding CE. So we do offer CE for this program for any Southeast chapter member. We ask you to go ahead and take a picture of this QR code. This is your way to complete the survey, which needs to be completed within 2 weeks of today. So the deadline for that is July 12th. Dr. Sorce will be sharing the same slide later on as well. There are some interactive questions that need to be completed along with your CE information to be able to submit. With that, I'd love for us to go over a few of our recent events that we're very proud of. So last month, May of 2023, we celebrated National Critical Care Awareness and Recognition Month. And our chapter was able to host and support a stipend across the Southeast region to different hospitals that signed up to celebrate their teams. And we appreciate everyone who participated. We appreciate the fun pictures that were sent over. This was just a small appreciation token to all our critical care clinicians who are working day and night to ensure safe and effective care to our patients. This month, we hosted a bite-sized lecture on the topic of reviewing a case of toxicology in a pediatric patient and the use of ECMO to manage the patient. It was a very, very interesting topic covered by a UAB group. The recording will be available on YouTube soon if you are unable to attend in person. Our upcoming meetings and our upcoming educational programs will be in August. So they start with an ultrasound course that will be hosted in Atlanta right before the Southeastern Critical Care Summit. It will be hosted on August 2nd. It's an all-day event with hands-on training. As of now, the class is about half full, and we're looking for anyone who's interested to attend this class. Please let us know. We've sent out emails with all the information to sign up. If you have not seen them, feel free to reach out on communications@sccmse.org, and we're happy to provide you with that information. We have a group of wonderful instructors who have given this class before and who will be able to, again, offer first class learning experience, hands-on experience with patient models. This class precedes the Southeastern Critical Care Summit, which is on August 3rd and 4th in Atlanta. For more information regarding programming and registration, please visit criticalcaresummit.com. Our August quarterly CE meeting will be on August 17th, and it will focus on a multi-professional approach to early mobility in the ICU. We will have a wonderful rehab team out of Johns Hopkins that will be speaking to us. You will not want to miss this if you take care of any ICU patients. So Highly encourage that you save the date for that, and the registration link will be sent out soon. September is is Sepsis Alliance Month. And during that month, we will be celebrating Spike Out Sepsis as an in-person event with an amateur volleyball tournament. This is a wonderful event where we raise money that actually goes towards Sepsis Alliance to raise both awareness as well as research for sepsis. The event will be held in Chattanooga, Tennessee, which is the location we were at last year. And this year it will be on Saturday, September 16th. More information will be sent out. We encourage you to save the date that day and to recruit teams all across your institution. There's no skill required. It's actually a really fun tournament with lots of advantages that you can use and raise money for to help your team, but also help Sepsis Alliance. In September, we're also looking at our next bite-sized lecture series, which will focus on PE management, which is a pretty interesting topic as well with a lot of contemporary evidence. So look for the date for that. You can support our chapter through Amazon Smile. You can also follow us on Instagram, Twitter, and Facebook. And if you have any suggestions, please, whether it's programming or anything else that you'd be interested in, or if you're interested in learning more about our chapter, we encourage you to email us at communications@sccmse.org. And with that, I would love to introduce Dr. Sorce. Dr. Sorce is the Founders Board Nurse Scientist, Department of Nursing Senior Scientist for the Division of Pediatric Critical Care at Anna and Robert Lurie Children's Hospital of Chicago. She is an assistant professor at Northwestern University, Feinberg School of Medicine, and practices as a pediatric critical care nurse practitioner in the pediatric ICU. Dr. Sorce is the president-elect for the Society of Critical Care Medicine and is passionate about breaking down silos in all aspects of care delivery and research. We have the pleasure of this presentation today. And with that, I would love to hand it over to Dr. Sorce. I will change the presenter so that you're able to share your slides.
Great. Okay. All right, you let me know when you can see my slides. Can you see them?
We can see them, but it's showing both slides. This one and the upcoming one.
It's showing presenter mode or? All right, hold on a second. How about now?
Perfect.
Okay, great. So I am really delighted to be here and to hear about all the wonderful things that you guys are doing at the Southeast chapter. You guys are really active and it sounds like you're having a lot of fun. So thank you so much for inviting me. And I'm happy to talk to you guys today about team dynamics. Do we really need it to improve outcomes? So I have no conflicts of interest. And this is the slide with the CE instructions. So I'll give you guys a second to click on or take a picture of the QR code. I'll present it again at the end. Okay, so our objectives today are to define team dynamics, to understand some of the research in team dynamics, as well as think about how can we apply team dynamic strategies to the workplace. And I'm super excited about your talk that you're going to have from the team from Johns Hopkins about mobilization, because mobilization is a perfect example of where you really need positive team dynamics to make that work. So I hope for those of you who are here today, you can apply what you learned today when you listen to the next talk. So let's talk a little bit about history to begin with. So Kurt Lewin was an influential social psychologist who was German born and moved to the United States in the early 1930s. He founded and directed the Research Center for Group Dynamics at MIT. And he defined team dynamics as positive and negative forces within groups of people, and that the groups alter the behavior of the participants. So by the mere fact of being in a group as a participant, that group acts very differently, and it could be based on what's happening outside the group. The groups have properties of the whole, and those are very different from the properties that the individuals come with to the group. And in order to predict group behavior, one needs to account for the group goals, standards, values, and how the group sees itself and how it sees other groups. So let's look at some more definitions of team dynamics. So the first definition is behavioral relationships between members of a group. The next one, I see the next one as a little bit challenging. So it's important that we think about it from all different perspectives. So team dynamics are the unconscious psychological forces that influence the direction of a team's behavior and performance. They're like undercurrents in the sea that can carry boats in a different direction to the one that they intended to sail. So if team dynamics are unconscious, how do we fix them? So just think about that. And then the last one I wanted to say is it's a term that's used to describe the interactions, attitudes, and behaviors between a group of people who are working together. So let's take a second and think about the teams that we work on. So just start thinking of it. And I don't know, Rita, if there's a way for people to shout out the types of teams that they work on.
We can unmute if people are interested, or if you guys would like to just maybe raise your hand, and then we can unmute instead of unmuting everyone in case someone is unable to communicate.
Okay.
So through that function, you're able, yeah, I'm looking at the chat to see if anyone is able to raise their hand.
Okay.
Okay, I see an answer that says ACLS and research teams.
Great.
Interprofessional ICU team.
Okay.
RSI, trauma, multidisciplinary ICU team. The stroke team. Residency leadership team.
So these are really great because there are different members. Oh, the volleyball team. Yes, that's a good team. So the purposes of these teams are all varied, right? So the volleyball team is to play a sport. So your goals are very different than, say, your liberation team, different from your stroke team, different from your RSI team. So these are all really great examples of the different teams that people work on. And so these are some of the teams that I work on, or that I thought of when I was putting this talk together. So the sedation team, the quality team, the medical ICU, the CVICU, the education team, the research team, all of those teams that you see listed in there. Code team, just one second. There we go. Was having trouble kind of clearing this off. The PICU team. So many different teams that we work on. It's really important to remember that we have a purpose that's a little bit different on all of those teams. And I'm so glad that someone put the volleyball team in there, because that really drives home the point that our purpose on teams is very different. So let's figure this out. Are you a part of a group or a team? So let's think about what makes those different. All right, so in the far left-hand column are all the things that make a group different from a team. So the members. So in a group, the members are independent, but they're interdependent on teams. Goals for the group are individual. So I may be part of a group of nurses, but my goals are my own, as opposed to my work on a team, my goals are shared with the team. So the identity, it's me, versus shared, it's we. Leadership, for for the group is often a single leadership, but in a team, leadership is shared. Products, what we put together, I have an individual product versus a collective product, as well as same for the reward, individual reward versus a collective reward for the group. Cohesion, there may be none, or it may be limited for the group, but for the team, the cohesion, there's a common spirit or esprit de corps that everyone embraces. And when we think about conflict, it could be reactive within groups, but within teams, it's expected and proactive. So if you think about the teams that we just talked about, maybe some of them could be groups, but based on what I read, it looks like they're all teams. So next time you're thinking about a team, you can think about, all right, how is this team comprised and does it share this? So let's go to some thinking time. And I want you to think about one team that you participate on that's highly functional. What is the purpose of the team? What professional groups are represented on the team? Is the team static or dynamic? Is there a hierarchy? What characteristics does it have that makes it highly functional? And if any one represented professional group left the team, would it still be highly functional? So let's just take a minute to think about that. Okay, so everyone's got a team in their head, and they've sort of answered most, if not all, of these questions. All right, let's now think of one team that is not highly functional. So what's its purpose? What professional groups are represented? Is it static or dynamic? Does it have a hierarchy? What characteristics are missing from the team that if they had them, they would be highly functional? And if any one professional group left the team or joined the team, so let's go with join the team, would it stay not highly functional or would it become highly functional? And if any one professional group left the team, would it be less highly functional than it already is, or would it improve? Okay, so now that you've got those in your heads, let's talk a little bit more about characteristics of high functioning teams, and we're going to talk more about the research now. So there's a fair bit of work out there in the business world about high functioning teams, because very commonly in the business world, you need a highly functioning team to either sell your product or provide services. The providing services is not very different in the healthcare world, but in the world of business, it is a lot about sort of everyone doing their job to make the business successful. So these are some of the characteristics of highly functioning teams. The team has inclusive thinking, participative leadership, there's engagement amongst the members of the team. Within the team, there's respect, trust, and openness. There's personal excellence. There's healthy conflict. Now, lots of people think conflict is bad, but there can also be healthy conflict which can drive the work of a high functioning team forward. High functioning teams are open to innovation. They have structure and clarity. They have a shared purpose or a shared meaning. This is what we're trying to do. They are adaptable. They want to correct mistakes. They have flexibility and can build consensus when they're determining decisions that they're going to take. There's psychological safety. They can handle challenges. They can handle change. They have pride in their workplace, and they have pride in the impact that they're making. So I'm hopeful that when you were thinking about your highly functioning teams, that some of these characteristics came out. So other than we want to be a part of high functioning teams with good team dynamics, why are they really important? So I'm going to use this study to demonstrate that. So Shapiro and colleagues just published last year this paper that's titled Mapping the Care Team in Pediatric Critical Illness, Longitudinal Trends in Team Networks. So what they wanted to really do is describe the team composition and then map the clinicians who interacted with critically ill children. And they looked at patients in an ICU and they grouped them into by length of stay. So less than 7 days length of stay or greater than or equal to 7 days length of stay. So when they looked at all these children, they had a sum total of 35 of them. And there was no difference in the standard demographics between the groups. So this is why I'm not showing it to you. So if you look here at the number of unique clinicians in the less than 7 day length of stay, you can see there were 14 kids. The average was 6.4 clinician touch points. If you look at those greater than or equal to 7 day stay, they had 36. Okay, that makes sense. Like the longer you're there, the more people you interact with, right? All right, now let's look at specialties. So for the kids who were there for less than 7 days, they had 2.6 specialties for the whole time they were there. But the kids who were there longer, they had almost 7. So you can see these are statistically significant, but not really unexpected. What was discovered is that these 35 children represent over 3,700 encounters by more than 294 unique clinicians. So let's see what that looks like. So let's take this patient who was only in the hospital for 4 days, okay? And the attending is this greenish color and the trainee is a salmon color. So you can see that there were 1, 2, 3, 4 different people interacting with this patient over 4 days. And this doesn't count the nurses, the respiratory therapists, the child life therapists, the social workers, the music therapist, and anybody else, okay? So this is only physicians. And you can see what the map looks like, right? It's pretty straightforward. Okay, great. Let's look at the next patient who was there for 13 days. And you can see how many different providers touched this patient over the course of 13 days. There were ICU providers, HEMOC, surgery, neuro, ID, and palliative care, and then one other. So now look at the map. Okay. Now let's take a patient who was there even longer. Okay, this is challenging, right? So you can see all these different touch points, all these different physicians from all these different groups, ICU, bone marrow transplant, nephrology, here's an other, palliative care, interventional radiology, neuro, ID, anesthesia, etc. Okay, now look at the mapping. So when you think about how many interactions there are with the patients that we serve, each one of these dots represents a team. If we don't have team dynamics, this is not just a map, but this is just a mess of how we are functioning in a unit managing critically ill patients. So it's important, team dynamics are important because there's so many opportunities for us to do better and interact with not only within our own team and with our own patients, but with the other teams that come into our unit. Okay, so let's look a little bit at the research on team dynamics. So as much as I love this study, it's fairly complicated. So I hope to be able to explain it to you in a way that's understandable. So Mitchell and colleagues published this in 2014. And what they wanted to do is they wanted to look at healthcare team dynamics, and they wanted to look at how affective behavior and cognitive dynamics come through in interprofessional teams. And so they wanted to see how that looked on team dynamics. So they invited 120 teams to participate in this study, and 47 of them did. So they got about a 39% response rate, which is not bad. And they invited them to participate in asking questions about professional identity. So like, what kind of team do you belong to? Like, who do you reflect? What profession are you in? Elaborative behavior. So for elaborative behavior, they asked, to what extent did the team members deliberate or discuss different ideas? They asked questions about effective conflict. So to what extent is there agreement or not that there's friction during discussion at a team meeting? And in affective conflict, this got at perceptions, communication styles, and the personality of the individuals. And then they also asked about interprofessional openness. So they wanted to know whether or not team members were open to using team members' knowledge and skills to complete a team task. Okay, so what profession did they align themselves with in professional identity? Elaborative behavior, did they or didn't they deliberate over things amongst the team? Did they or didn't they agree whether or not there's friction during discussions, and whether or not they were open to using each other's knowledge to complete a task? Okay, so this was a heavy hypothesis-driven study, and they hypothesized that professional diversity will be positively related to effective conflict, and that professional identification is going to moderate the relationship between how much diversity there was and effective conflict. So meaning that as professional identification increases, like the more the group identifies differently, the relationship between diversity and effective conflict also increases. I'm going to let you read the last of them. And some people say when you're giving a talk, you should put very few words on the slides. I know that people learn in all different ways. So some of you are going to learn just by listening. Others of you will learn by listening and reading. And some of you learn best by reading. And so that's why I'm making my slides have a lot of words on them. So I would appreciate any feedback anybody has if you think these slides need to be more divided. Okay, so let's look at the results. Okay, so this is their correlation coefficients, and we can see anywhere with the asterisks are where they had statistically significant outcomes. And these are just correlating professional diversity, and let's go here, to elaborative behavior. So more professional diversity was correlated with less elaborative behavior. Okay. Let's see, affective conflict, more affective conflict with less elaborative behavior. And then openness, let's see, affective conflict with less openness, which you would expect, but with professional identity, more openness, and with elaborative behavior, more openness. Okay, so I'm going to tell you the results by hypothesis. So essentially, the first one was a non-significant positive result, and the others were all statistically significant. Okay, so not going back to each one of them, let's just talk about what it all means. So what they found was the greater professional diversity in teams that also had greater professional identity within the team, there was more affective conflict, they were less elaborative, and they were less open. So it seems that, based on their research, professional identity is what moderates these activities. So the more I am steeped in being a APP within my team, the more each one of the members of the team is steeped in that, the more there's going to be conflict, the less elaborative behaviors, and the less open the team will be. So as a result, they recommend that there should be strategies to decrease conflict including creating shared goals, values, and using transformational leadership to get to that. So really, this study is about how and why are teams dysfunctional and how can we make them more functional? What's at the basis for their dysfunction? So let's move on to our next study. So this was a qualitative study that looked at moral distress in the ICU team and the importance of unit functionality and within team dynamics that was published in 2015 by Bruce. The purpose was to determine the sources of moral distress and how it's managed in team-based models. It was a qualitative study that was using case studies of 3 cases that clinicians and ancillary staff involved in the cases knew about, and it was in both medical and surgical ICUs, and they interviewed the clinicians. The interview guide contained 5 topics, including what was the source of moral distress and the time in the case that it appeared, how it impacted the clinician and the patient care, what were the interventions to mitigate the moral distress, relationships throughout the case, and whether or not the case could have had a different approach and whether or not that approach could mitigate the moral distress. So let's see what happened. So these were the participants. You can see that there were a total of 29 participants, including 16 nurses and 6 physicians and 7 ancillary staff. So the ancillary staff was comprised by RTs and social workers and other allied health professionals. There were 14 that participated from the medical ICU and 15 from the surgical ICU with similar nurse and physicians. It was primarily female with no male nurses in the group and 5 male physicians and only 1 female physician. And the range of experience you can see from 2 to 32 years across, with the exception of the physicians 2 to 25 years. All right, so that tells you the who. All right, so let's look at this. So sources of moral distress. So intra-team discordance, what did they find? They found that what caused distress within the team was the perception of non-beneficial treatment. And 16 nurses said it, 6 docs said it, 7 ancillary staff said it. So everybody said that. 14 in the medical ICU and 15 in the surgical ICU. So this was really something that everybody felt. Lack of full disclosure. Only 13 interviewees felt that there was moral distress due to lack of full disclosure. 8 nurses, 2 docs, 3 from the ancillary staff, and everybody was in the surgical ICU. Discordance between the clinician and patient family. So everybody felt that across the board, and intra-family discordance, everybody felt that across the board. So what maladaptive behaviors did people use? So you can see here that they used a variety of them, but the most commonly used one was desensitization. And that was used by more than the others. Okay, it's unfortunate that we see fighting still, but that was used. But then what constructive behaviors were used to try and mitigate the intra-team discordance? So venting, it looked like a lot of people used that, and you could see it across the board. Mentoring was really not used very much. And building team cohesion, I'm glad to see that that was used more than mentoring, but it still was much less than half the number to mitigate these inter-team discordant dynamics. So what does this really tell us about team dynamics? What it tells us is moral distress is found within our teams when we perceive that there's non-beneficial treatment going on and patients don't have full disclosure of everything. And this then leads to altered team dynamics. So the team then engages in maladaptive behaviors. And so we can see that this is one of the pieces that sort of drives team dynamics in a negative way. Okay, let's look at our next study by Foster and colleagues. And they looked at optimizing team dynamics, and they looked at physician trainees and APPs in collaborative practice. So they wanted to look at staffing models that include APPs and trainees and the related outcomes, and look at strategies to promote collaboration. So this was a systematic review, and they were able within their systematic review to look at 21 total papers. So they found that patient care outcomes improved with the addition of APPs to the model, to the ICU model. There was decreased ICU length of stay, UTI, skin breakdown, hospital costs, readmission, and 30-day readmit. They also found that there was no change in ICU length of stay, readmission, mortality, event days, and disposition in other studies. There was more collaboration amongst team members when APPs were added to the team. And learners, there was mixed results on the learners, on their educational opportunity. So why do we care about this? Well, we know each one of us practices in a unit that is probably a little bit different from another unit, or even within another team in your unit if you have more than one team. And the models, because they all vary, there's variable team dynamics. While this is still a good study to talk about in it being a systematic review, we know that systematic reviews and studies are limited by study heterogeneity, the way intensivists or attending physician model staffing are created. Our units have hugely variable characteristics. I work in a 40-bed unit, someone works in a 10-bed unit. Those dynamics are going to be very different. And some work in a neuro ICU, others work in a gen med ICU, others work in a surgical ICU. So it's really hard to bring all those factors together to say, okay, this is the best way to create team dynamics because this is how X unit with X number of beds and X characteristics did. Okay. All right. Let's look at another study that was done in a low resource cardiac intensive care unit. And they used simulation training to look at team dynamics and performance. So specifically, they use low fidelity sim, and they use training teams. They use a training to see if they can improve team performance during crisis, and like I said, in a low resource unit. So the method that was used was a prospective observational study that included 3 healthcare providers. It was 8 nurses, 8 anesthesiologists, 6 surgeons, and a cardiologist that participated in 4 simulation sessions during a 5-day training program using both didactic and sim. So the participants took a pre and post sim survey, and then they repeated it at a month. Like I said, I explained all the participants, but they were divided into 2 groups. So each group had at least 1 surgeon, an anesthesiologist, an intensivist, and then 3 to 4 nurses. So what were the results? So group 1, again, they were equivalent groups, and they both groups got the same thing, but group 1 had a significant increase in total frequency of communication, whereas group 2 did not. Both saw improvements in role clarity over time, and in daily surveys that they took, there were significant improvements in role clarity, effective communication, and idea acceptance. And team dynamics remained stable at 1 month after the course. So let's look at this in terms of their graphs. So group 1 is closed and group 2 is the open squares. So you can see that role clarification improved across both groups. You could see that time to respond to low blood pressure decreased over time, which is great, which we want. Time to bagging also decreased over time, which we want. But this is the only place where there was statistical significance between the groups. So group 1, being the closed group, they had better closed loop communication over time. So that tells us that teams getting the same opportunities in education, didactic, and simulation can respond very differently. So I think that when we think about our teams, that tells us that one size doesn't fit all. So something was going on in the second team that sort of prohibited statistically significant improvements in those other three areas. And something was actually going on also in group one that stood in the way of statistically significant improvement in the other three areas as well. But let's look at their post-sim responses, and you can see that they strongly agreed with being more comfortable speaking up, improved role clarity, being more likely to use closed loop communication, and they thought they had improved team dynamic. And then there was agreement, and then only one was neutral on more likely to use closed loop communication. So while the outcomes that they measured only showed one of the concepts being statistically significantly improved, everybody felt like things were a lot better. So that's good, because then people will continue along that pathway. All right. So let's look at our next study. So Lucrezia and colleagues published a couple of years ago about standardized work rounds and looking at how teaming, comprehensiveness, having a shared mental model, and achieving a rate of end of shift goals would look like. So the purpose of their study was looking at standardized nurse-led rounds and the impact on the frequency of ideal team behavior, how comprehensive rounds were, whether or not people had a shared mental model, and they achieved their goals. So the goal achievement, the way that was measured, was the goals that were set in round, whether or not they achieved them by the end of the day. So this was a prospective observational cohort study that used 154 rounds encounters in a 28-bed PICU. And their standard PICU work rounds, again, were nurse-led. They were observed and recorded by 2 individuals, and participants completed a blinded questionnaire immediately after the post-observation. So what they wanted to look at from team behaviors were attentiveness, explicit prompts for the family or a team member to be included, task allocation, like who was responsible for it, who did it get allocated to, whether there was clarification on data prompts, and summarizing rounds. The shared mental model was the percent congruence on the principal diagnosis, the overnight issues, goals, and anticipatory guidance. So did everyone see those things the same? They collected patient level data and team composition, and they had data that they had collected prior to nurse-led rounds, after the didactic education, and they did 2 cycles of this. So this is the descriptive, let's say, the conceptual map that they followed. The inputs to the map were the team, so the composition and the hierarchy, the experience, how familiar the team was with themselves, with each other on the team leadership, the nature of participation in the team, then the individual participant, what was their subject area expertise, their interpersonal skills, their cognitive capacity, experience, performance expectations, adaptability and flexible, and the individual teaming experience, like have they never worked in a team before, or have they for a long time. The patient and the caregiver, so they looked at medical complexity, the condition that the patient had, how stable they were, the family's experience in the hospital, what were their expectations, were they familiar with medical language, what was the active medical care going on, and then organization and environment, so things that were specific to the unit, the equipment, how the unit functions, what time of day it was, the safety culture, and the existence of protocols and procedures. So then they looked at processes. So the academic processes that included identification of knowledge gaps, learner perception management, then parent and caregiver progresses, so building trust with the parent and the caregiver, addressing their concerns, over to team processes, shared language, excuse me, power gradients, how were they leveled, task allocation and prioritization, anticipating emergent states, shared goal development, and then participant processes. So how active were they, closed loop data exchange, conflict management, situational awareness, and data interpretation. And then they looked at their outcomes. So the outcomes of prototypical teaming, as well as, so that included transdisciplinary leadership. It included creation of common ground, informed decision-making, shared goals development, leading to the data exchange. So important information about the patient, as well as anticipatory guidance and quality and safety, making sure there's quality and safety review. And then the shared mental model, like how much agreement is there, or they want high agreement between the team members, clear expectations for what the team members are responsible for, and their performance, as well as predicting emergent states. And then these were the goals that are based on their model: quality healthcare, culture of safety, patient and family satisfaction, workplace efficiency, participant satisfaction, as well as reduced hospital costs, improved patient outcomes, and medical education. All right, so this is their model that they're working in. So a lot of moving parts. So let's see what happened. So this is what the team composition was before and after they standardized this process. It's important to know ahead of time that the patient level data that they collected included things like age, gender, diagnosis, length of stay, their index of mortality. They looked at additional severity of index markers, frequency of mechanical ventilation, non-invasive ventilation, renal replacement therapy, ECMO, and vasoactives. So let's see how they did. So pre-intervention, you can see there were 346 opportunities, and then they had a PDSA cycle that was 385, and then people, and then 356 people in the in PDSA cycle 2. So there was really no difference between how many people participated. And you can see that the only place that there was two differences, statistically significant differences, were in a clinical pharmacist being present more in PDSA cycle 1, and a dietitian being present more in PDSA cycle 1, okay? And that may just be a function of their unit. But there was no difference in bedside nurses, rounding nurses, RTs, resident physicians, attendings, or APPs. I'll say that for the respiratory therapists, even though it's not statistically significant, it did go up. And that was because after PDSA cycle 1, they included respiratory therapists on patients who had pulmonary diseases. Okay, so let's look at the team science factors, all right? So they, so no side conversations, that didn't really change. So there were still side conversations going on after they started this process. The bedside nurse saying that it's okay to start, that changed significantly, because remember, these were nurse-led rounds, and that was stable between the two cycles. The leader was clearly identified. That approached statistical significance because it got to 100% in PDSA cycle 2. So it was already fairly good. Prompt for questions, 68% of the time. That didn't change. Prompt for inclusion, that came close to changing. Full attentiveness by participants. It looks like there already was really good participation. Closed loop communication definitely improved between the pre and the post. That was statistically significant. Family inclusion, although not statistically significant, it did improve. And then clearer assignments of responsibility definitely improved. So that's great. But what else? So let's look at this idea of the shared mental model. So one might argue that if everyone has the same shared mental model, then the team works much more strongly together. So let's look at this. So before the intervention, on principal diagnosis, really, they didn't have much agreement, only 42%. But if you look at after the introduction of nurse-led rounds, there was much greater shared mental model on the principal diagnosis, the overnight events, particularly between PDSA cycle 1 and 2, end of shift goals, significant between pre and PDSA cycle 1 and 2, as well as anticipatory guidance. So all of these were factors promoting the shared mental model index. And if you took them all together, even together, not only individually were they statistically significant, but together they were statistically significant. So what does that help us learn? So achievement of goals being set during rounds was associated with the strength of the shared mental model, regardless of who the attending was, the APP was, the resident provider, the length of rounds, or how sick the patient was. So it tells us that this is a good way to create some team dynamics. Okay, we're going to move on to our next study. We're going to talk about psychological safety. I had the extraordinarily good luck of listening to Dr. Zanotti present grand rounds in Texas just last week. And he talked a fair bit about psychological safety. And there's a fair bit of information about psychological safety in the business world. So I just wanted to introduce this as a part of team dynamics. And if you remember back to that slide where we talked about characteristics of high functioning teams, psychological safety was in there. So let's talk about this study that was just published. And I realize it's in emergency medicine, but I think that it's useful to think about this. So this team sought to evaluate how psychological safety manifests, how it's fostered, and if it's threatened within emergency department teams. This was a mixed method study, so quantitative, qualitative, that included 72 participants, that included nurses, consultants, registrars, and nurse educators. All participants completed 2 surveys. One was the Team Learning and Psychological Safety Survey, and one was a narrative survey. The narrative survey looked at speaking up with concerns, belonging, and power, whereas the Team Learning survey was a survey that measured psychological safety with 7 items that used a Likert scale that looked at teaming, learning, speaking up, and risk-taking. 19 of the 72 participated in the qualitative part, or the interview portion. So we can see that mean psychological safety score was 35.5 out of 49, and that the individual role and the time working in how much time someone spent working in the ED or their experience were associated with psychological safety. So let's look at some more information. So work role in the emergency department, whether or not they felt psychologically safe or not, that was statistically significant. So you could see that the consultant had the highest. So a consultant is the equivalent of our attending physician. Registrars are our fellows and registered nurses, and then nurse educators. So you could see there was a statistically significant difference between the groups feeling psychologically safe. And then length of time working in the emergency department. You can see that the longer you work there, so those who worked there greater than 5 years, had the most psychological safety. But let's look at then what they talked about. Hold on, let's go back a second. How do these compare? So when you look at pairwise comparisons, Consultants had higher psychological safety than nurses. We can see that, but when they put them together in pairs, that rang true. And registrars also had, when compared to the clinical nurses, higher level. And those working in the department, when they compared them, those working greater than 5 years, then 6 to 12, you can see that comparison was also statistically significant. Okay, so let's talk about the concepts that came out of some of the qualitative stuff. So the bigger the box, the bigger the concept. So when it came to the team, familiarity with team members was the primary thing that impacted team dynamics. That impacted psychological safety. Status, hierarchy, inclusiveness was the next greatest. Whether or not they had peer support was the next highest. Leader support, then familiarity with the leader and leader behavior. You can see then there's other concepts that also apply to psychological safety, including what's the culture of safety? That was the biggest one. Continuous improvement culture, and then familiarity across teams, and then whether or not there was organizational support. And if you look at the individual, it seems to have the least impact on psychological safety. So my professional responsibility and my individual differences. So familiarity with team members seems to be the biggest impact on whether or not people feel psychologically safe. So I want you to think for a minute, the last time you were on a team that you were a newbie. How safe did you feel speaking up? What do you think that did to the team? Do you think it detracted from the team? Do you think the team was just fine because you were new, so maybe you think you didn't know what you were doing anyway? Or did the team suffer because you had something really great that you could have said, but because you didn't know the team very well, you were a little bit intimidated or shy to really give that information up? So let's talk about how do we do team dynamics in the workplace. And we're going to start right where we left off, back with the Purdy study that was just published. So these are the things that they recommend that would kind of help with familiarity. And this is towards the emergency department, but I think that we can think about this stuff in terms of the ICU. Really shift huddles. So simple introductions, teamwork, setting expectations, lowering the communication threshold. So by having a shift huddle, like everybody could talk because it's informal. Team briefings. So what is our team expected to do today? Rapid development, what's the knowledge? After action review. So fostering this positive regard and identification for areas of improvement so the team could grow together. And then for the department, developing simulation, creating schedules that are designed to build familiarity, and induction. So powerful places to introduce people as much as possible. That's a process, and fostering a sense of belonging. So these are some things that we can do to improve psychological safety, according to Purdy and colleagues, so that if you have greater psychological safety, that is one of the characteristics you will have of a highly functioning team. Excuse me. So how else can we do this? So Rock and colleagues published in CHEST this study, Transforming Team Culture Through Curiosity and Collaboration, a case study for critical care. And within a group, there were some clinicians that identified that they needed help with interactions that were affecting their collaboration. And it was 18 nurses, physicians, and fellow trainees, and they participated in two-hour workshops with a nurse and physician expert facilitator. The facilitators described the culture as dysfunctional with distrust and skepticism. And they mapped a causal change that started with assumptions and intentions that led to a particular actions that produced clinical and social results. So they really wanted to apply an approach to shift the team culture by creating a reflective space for interprofessional clinicians that would be able to then value and understand each other's perspective, roles, and responsibilities. So they did 3 days of observation and informal interviews, trying to suss out what the greatest areas of concern were. And what they found is that there was a climate of animus, there was a lack of team cohesion, and cohesiveness, and there was not inclusion of team members in team discussions. All right, so they put together these workshops that were designed to recognize and value others' perspectives, decrease stress, and provide education on conflict resolution techniques that would then result in clinical collaboration. So they used a fictional story to examine their culture using reflection. And frankly, before they could do any of this, they had to establish psychological safety before they could introduce this learning pathways grid that I talked to you about, and how new assumptions could inform new insights to enable teams to sort of redesign their interactions. So what did they learn from all this, the participants? They learned that they need to understand each other's perspectives and goals. They need to feel valued, they fostered mutual trust, and they need to care about others' perspective and experiences. So let's look at this just for a minute. So the toxic phenotype and communication pattern is all the way to the left with an example, risks, and then what was the strategy that they used to overcome this. So the one toxic phenotype was fight. I'm right and you're wrong. And the example that was given was, just because you can doesn't mean you should. Dialysis is a path to nowhere, and it's not going to save the patient's life. So the risks in that is that they're thinking that there's only one answer, using a hostile tone, and then feeling unvalued, that we all know contributes to burnout. So instead, how could we say that in a way that is more respectful, uses more of a collaborative approach? So let's talk about it again. I hear you saying a time-limited trial makes sense because we might be able to get them home with this family, which is meaningful and maybe the patient's goal. Can you please talk me through my concern that this is not going to work and that the patient and family are already suffering? Please, what are your thoughts? All right, so silence, right? Oftentimes, or not oftentimes, but there are times where you will go to a bedside and you'll say, all right, this is our plan. Based on the things that you helped us understand a little bit from this morning, we're going to do this. And then the person you're talking to is just dead silent. They don't say anything. And then, you know, after you leave, they turn around and start complaining to their neighbor. The risks is that the silence is not recognized, perspective is lost, and burnout and moral distress occur. So instead of being silent, people can ask, I'm having a hard time understanding this. Can I talk to you? Or I can say, well, I notice you're not saying anything, and I think maybe you might have something. Can we talk about whatever's on your mind? So each side of that communication has to be willing to step forth. Read my mind is the next one. Master of passive aggression. Maybe we should just put everyone on dialysis tonight, is what's said. Now that, you know, really using sarcasm isn't helpful. It doesn't help the patient because you're not actually talking about your valuable perspective. And instead, you can say something like, well, I have some reservations about this because of what happened on his last admission. You probably have some other ideas and other data. Can we talk about this? Caustic humor. Just because he has lungs doesn't mean he belongs in this ICU. This patient is not getting admitted to this unit. Negative emotions. They can really hamper our cognitive processes as well as our collaboration. So instead, one can say, well, let's talk about this appropriate disposition. I recognize that the patient has complex hemodynamics, and I know that the primary diagnosis is sepsis, but really, can we review this together to see where he most likely fits best? Impatience, that urgency impairs our ability to listen. It results in too few data being shared and then as a result, poor decisions. A more effective way of getting over impatience is, I'm wondering what changes you have to report, knowing that you've been taking care of this patient for many hours today. What's your sense of things? And then frustration. So we argue out of a place of emotion, and you're not putting the data in. So are you even listening to me? I'm worried about him. You have to do something. So I've had people say that to me, and that can feel very, that can be very hard to take that in. And so then it's up to me to say, all right, let's talk about what you're concerned about. Tell me what your findings are. If I say, yeah, no, the kid's fine, just keep monitoring X, that's very dismissive. They're not going to speak up again. It will not move patient care forward. But instead, asking them about, what are your concerns? Please tell me. So these are some of the things that they found in their work. So we've heard lots of times that there's no I in teamwork, but as presented by Dr. Rudder Rice, who was kind enough to share this with me, maybe there is. So I and we are complementary in teams. You need I for personal development, self-esteem, motivation, involvement, performance, and work quality. Like, I need to bring me to this team so that we together can have a good team dynamic. So I represent the belief in oneself and my quest, or an individual's quest for accomplishment, and the we represents the commitment and the allegiance to the team. So I'd like to leave you with a few last thoughts. I recently had the opportunity to attend the National Teaching Institute, which is the AACN meeting, and Abby Wambach, the former soccer player, was one of the keynote speakers. And talk about team dynamics. Wow, if you don't have good team dynamics on a professional sports team, then your team will fail. She talked about having courage and self-awareness and respect to create good team dynamics. But she also talked about facing failure and memorializing failure so the team doesn't create that failure again. And she used the example of when she was just a wee whippersnapper in her teens, she had the opportunity to go to a practice field where Team USA practiced, or a professional team practice. And they had lost the year before, and they had a picture of the team having lost outside just as you would walk out of the locker room. And she thought to herself, why would they ever want to remember that? That was horrible. And what she talked about is, if we don't memorialize our failure, if we don't face our failure, we are bound to commit it again. So within our teams, it is critical that we engage our teams, we face our failures, we have respect for one another, we're self-aware, we bring our best selves, and we're courageous to improve team dynamics. So we do need team dynamics to improve our patient outcomes. So here is another opportunity for you to take a picture of the QR code. I'll let you get your phones out. And if anybody needs me to repost it, please let me know. And I'd like to thank you for listening. And I would be more than happy to take questions.
Thank you so much, Dr. Sorce. This was very, very interesting. If the group, if any of our attendees have questions, please drop them in the chat, and we'll be able to take them from there. I think I can start us off maybe with one question that I've experienced and have seen over the years. What would be your recommendations and suggestions on reestablishing good team dynamics after there's been a conflict, or there's been a breach in trust, or some of the negative experiences that you described, the talking or sarcasm or side conversations that don't contribute to the larger conversation.
Yeah, you know, I just had this conversation with a colleague of mine who is struggling with a team. And I think that there's a variety of ways to go about doing this, right? And everybody has their own level of comfort in facing conflict. And when trust is breached, that's conflict. And so certainly honesty about what happened from your perspective, and honesty about expectations moving forward, I think are critical pieces to reestablishing trust. Trust is a really, really important thing and super hard to regain once you lose it. And it takes a lot of time. And I use the example, whenever I talk to brand new fellows, I said, in less than 10 seconds, frankly, in negative 10 seconds, a nurse will know if you don't know the answer to the question and you're just trying to get out of it or figure your way out of it. The nurse is going to sense that, like nurses can smell that a mile away, right? And when you do that, you've already destroyed the trust that the nurse gave you because you've gotten to this level. And now you're going to spend however much time reestablishing that trust. So honesty and conversation is, I think, one of the first pieces. And as you move forward, engaging and saying, oh, this has gone really well. Thank you very much. This has gone great. Let's, and keep moving forward with setting expectations and having open and honest conversations. But you got to have courage to do that. And that's hard. And when you've been burned once, it's sometimes hard to go back to the fire. Should I stop sharing my screen?
I think someone was asking if we can reshare the CE slide. That would be wonderful.
Absolutely. Yep.
Thank you. Thank you very much for that. That is, I think, a very practical, very honest answer. So thank you for sharing that.
Of course.
We have another question here that says, you mentioned a study that suggests more conflict when folks are fixed on their professional identity. Some literature suggests folks should have professional identity and separately interprofessional identity formation. Thoughts on this identity validation theory as it relates to team dynamics?
Yeah, so that's great. So I agree. People need to have professional identity for sure. And I think it's important because we bring that to the table, right? We bring what we've learned, how we've learned it, our science individually to the group. But when that is used in a way that is supersedes the needs of the group or supersedes what, like, well, I'm a nurse and I would never do it that way. Or as a nurse, we should be doing X, Y, and Z. That professional identity, that is not contributing to the team in a positive way to impact outcomes. So while I agree we need to bring our professional identity because that's what makes the teams work overall, because we each add to the patient outcome. In the study that Mitchell did, they showed that the higher the professional identity, the more conflict that there was. So it's not that it's good or bad, it's that the more that there is, the less effective the team is. So it's a matter of gradient. Did that answer the question?
I believe so. And if we are looking for any more clarification, please drop it in the chat. Dr. Sorce, as you were speaking, one of the things that came to mind was some of the shared tragedies that we face as a team, and that can be the loss of a patient or the loss of a team member. and it certainly affects team dynamics and team morale. What are some strategies to address those?
Yeah, so I worked with one of our nurses over the last several years, and I'm sure many of you have some of these strategies in your units, where you have rapid reviews of resuscitation or reviews of patient death, resuscitations that result in a spontaneous return of circulation and those that don't, where you bring the team together, whatever the team is. So it may not be your typical, ICU team. It could be a different team. We bring the team together after the event to actually talk about it. There's data that shows that positively impacts the team, that people feel value from coming together to express what they felt, what was good, what could have gone better. It's an opportunity to share information. When I think about, let's say, a code in the unit, and the code alarm goes off and everybody goes running, and it may be a patient of mine and it may not. And more importantly, if it's not a patient of mine and I observe what went on, and from my perspective, it was a dumpster fire, I would have the opportunity to go to the review of what happened, that typically in our unit is scheduled within an hour, and say, this is what I saw happening. Can someone please help me understand? And then the people that are involved in the care have the opportunity to educate me and tell me about how things went, so that I can walk away from that situation being less impacted by what I perceive to have been really just a horror show. So I do think that implementing strategies like that have been very effective. And we've engaged, we have our, initially with the research that we did, it was led by the people who were doing the research, but we also have now, anybody could pick up the guide to do the work and run one of these sessions. So that has been very successful. There are also less formal things that can be done, people supporting one another, seeking out a trusted colleague to review what happened, asking for feedback. What could I have done better? Was there anything I could have done better? Was this just a fait accompli to begin with, and we just tried our hardest, even though we knew that this patient was not going to have a good outcome? So I think having the opportunities, whether it be in a more formalized process that is like informally formal, or informally, I think amongst colleagues and other members of the team, I think are helpful ways to keep the team invigorated. And of course, all the things that we try to do to improve our well-being, whether that's individual things or things that we could do as a group.
Thank you very, very much.
You're welcome.
I do not see any further questions in the chat. Well, I would like to thank you again on behalf of the chapter. This was very applicable to all our practices, regardless what our clinical profession is or what our clinical background is. We appreciate your time, and we'd like to thank you, and we can't wait to hear from you as president next year. And I would like to thank all our audience for joining us today. We will see you again August 17th for our talk on early mobility in the ICU. Till then, please stay safe and enjoy your summer.
Thank you very much. And if anybody else has any other questions, please feel free to reach out to me. It was really delightful presenting this for you today. So thank you.
Thank you. Have a good one.
You too.